At the onset, I would like to thank IOA and ASSI for giving an opportunity to present on unilateral biportal endoscopy, which is a novel technology and very useful in a lot of spinal pathologies. Today, I'm going to focus on the use of UBE for decompression of single level simple lumbar canal stenosis. Just to go through the basics, what is UBE? It's an endoscopic technique which uses two ports. So there's a working port and scopy port. Unlike the transforaminal endoscopy, where the portal is the same, the scopy and the working portal is only one. This technique is useful for a variety of indications, right from PID to lumbar canal stenosis and spondylolisthesis. Today, I'm going to focus of its use in LCS. This technique was described way back in 96 by D. Antoni and Claro, later popularized by Abdul Ghaffar, and in South Korea by Jin Yum. I was fortunate to receive some training in South Korea with Dr. Som and Dr. Yuden Wa. So for orthopedic surgeons, this is a very appealing technique because just like knee arthroscopy, there are two ports. But in knee, you have a actually existing cavity. But in spine, there's a potential cavity which you exploit for this technique. One has to learn how to do triangulation. And since we orthopedic surgeons are trained in knee scopy, it is quite easy to do this. There is an inflow portal and an outflow portal. So what is this working space? This working space is a potential space underneath the multifidus muscles, just adjacent to the lamina. And what you do is that you put in saline through the scopy portal and expand this space and exploit this potential space. So by hydrostatic pressure, you create this working space. And then from another port, you put an instrument from which you do all your work. So you have to learn this triangulation so that through one port you visualize and through other you do the work. If there is too much distance, then it is called as open triangle. You'll not be able to see your instruments and not do a good job. While if you cross the scope and your working instrument early, then it's an early triangle. So in the center, what you see is what you want to do. You will want to visualize your working instrument through the scopy port. So getting right the triangulation is very important. So as you can see here, that is the scopy portal and a working portal. So for lumbar canal stenosis, to use this technique, you have to have a good patient selection. So ideal patient is one who has got radicular pain or claudication, not responding to medical treatment for 6 months, and MRI confirming stenosis. It is not a good technique if there is segmental instability, degenerative scoliosis, or recurrent stenosis. You can still do it, but you need a lot of expertise. So the case I'm going to present is an 81-year-old male with severe progressive claudication affecting quality of life, unable to walk for more than 10 feet, having pain, tingling, and numbness in both limbs, hypertensive, diabetic, previous history of DVT, treated case of lymphoma, no response to physiotherapy, epidural steroids, and pregabalin. So as you can see on the plain X-ray, there is no instability, no degenerative scoliosis. And on the MRI, you can see severe stenosis at the L4-5 level. So this is an ideal case for this technique. Let us go through the technique. So this is the OT setup. So this is done under GA, prone on bolsters or Hall-Relton frame. And as you can see, you need a C-arm, you need the arthroscopy trolley, and you need other gadgets as well. So the arthroscopic equipment, you need a camera, you need a light source, a monitor. And for this technique, you can use a 4mm 0° or 30° endoscope. The other gadgetries are arthroscopic shavers or burrs and radiofrequency cautery. No specialized spine instrumentation is required. You can use your ordinary Carrison's disc forceps. A special Carrison called rotating Carrison is of help. So what is important is to how to place the portal. It is placed between the mid portion of spinous process and upper part of the disc, and midline between the joint and spinous processes. Now, which portal is caudal? So for a right-handed surgeon, if it's a left-sided major pathology, then the scopy portal is cranial and working portal is caudal. While for the right-sided pathology, the scopy portal is caudal and working portal is cranial. So you mark the disc, the midline, the medial pedicle line, and mark your portals. And then you insert a 0° 4mm scope, and through the other port you can insert all your working instruments. You can insert the burr, the radio frequency, and Carrisons. So this is how you work, with one hand steady in the scope and with the other hand doing all the fine work. So initially when you start, you usually see a field full of blood, and then so slowly as you clear the soft tissues with the RF, you clear the lamina, you burr the lamina, and then you see the ligamentum flavum, and then you enter this epidural space. So to go ahead with the patient which we just saw, this is the scopy of the case I presented. So initially, this is what you see. I call it as a sunrise appearance. And then as soon as you start clearing with the radio frequency, the lamina becomes more and more visual. So you need to put a radio frequency on the lamina and just gently dissect off the soft tissues. So here you are exposing the ipsilateral inferior half of the lamina and clearing off the muscles from there. Then you use the burr and start drilling the lamina. So here you can see the inferior edge of the lamina being drilled. So the starting point is the junction of the spinous process and the lamina base. So from there you start drilling proximally and laterally. So you feel the bone and you drill. You need to stop in between because all the bone dust which comes needs to go through the outflow. So their field remains clear. And by the feel, once you take off the outer cortex, you start reaching the cancellous bone. And once you drill the cancellous bone, you will reach the inner cortex of the lamina. Here you can see on the base that whitish thing is the inner cortex of the lamina. And then you expose the ligamentum flavum. Then you can put the dura just at the proximal end of the ligamentum flavum. And with the hook or the dura, you can just peel off the ligamentum flavum, as you can see here, exposing the epidural space and the dura. Then you start decompressing the lateral recess and peeling off the lamina. So here a 3 mm Carrison is being used, and through the working portal, I am taking off the ligamentum flavum, exposing the cauda. So the central part is first decompressed, and then you go laterally underneath the lateral recess and start decompressing the lateral recess. So you can put a hook, as you can see here, and feel the lateral recess and slowly undercut the lateral recess. And as you go deep, you will find the lateral recess being decompressed. So again, this is showing the Carrison being used to undercut the lateral recess, and then feeling the lateral recess. That is the disc underneath, you can see there. So the lateral recess is now free, and that is just the shoulder of the root. And then you can follow on the root to go inside the foramen and free the nerve root. Then you direct your Carrison to the opposite side and start taking the phlegm of the opposite side. So this is the phlegm being taken off from the opposite side. So you put your Carrison between the phlegm and the dura and gently tease off the phlegm. So here you can see the severe stenosis, the hypertrophied phlegm in the lateral recess and going into the foramen. So slowly you start using your instrument. If there is a bleeding, you need to check the outflow, and you can use radio frequency to stop the bleeders. And here you can see the opposite side lateral recess being decompressed, and slowly the opposite root being exposed. So that is the root on the other side. So on the 6 o'clock position, you can see the chorda, and 12 o'clock is the nerve root on the contralateral side. So you can do a good bilateral decompression. And here you can see that that is the central fold of dura, absolutely in the center, and on both sides being decompressed. Then you insert a drain and do a closure. So this is the same patient which we showed before, pre-operative scans and post-operative scans showing excellent decompression. So there is less damage to soft tissues, faster recovery. You can get them up same evening, can be converted to open if required. There's hardly any blood loss, less hospital stay, decreased infection rate, less complications, and less radiation. So this is the same gentleman who has come for a follow-up after a week, and absolutely no pain, and all his symptoms had improved. So the disadvantages is that you need a lot of gadgetry, you need training, there is a learning curve, but as slowly you train yourself, you can master it. So anyone who stops learning is old, whether at 20 or 80. So I think this technique has got a good future, and all of us need to slowly try and adopt this technique. Thank you.